Great.
Okay, that's good. All right.
Mhm.
Um, okay, so I see that some of you folks have seen me or had surgery with me, or are coming to see me, but just a quick introduction. My name's Ellie Zara Lay. I mostly go by my middle name, which is Zara. My pronouns are she, her, they. Um, I'm Chinese Mexican immigrant. I'm a member, obviously, of our community, and I'm one of the few trans women surgeons, plastic surgeons that dedicate my whole career to gender surgery. So I feel very privileged to be able to help others as others have helped me in my own personal journey. Um, Not just through the general transition and support, but also, of course, the surgical portion of it. Um, just like Rai said, we do bring up some anatomical um, pictures, but also terms, and it's not meant to ever like hurt anybody. But we have to, say certain things that are medically acceptable. And I think for the most part, it is fairly correct, but some people can be very sensitive to it, such um, as I am myself as well. So, and I try to be inclusive. One of the disclaimers I will say is that in the past, not just me, but at other meetings and presentations, there may be maybe like a lack of diversity in terms of the pictures. And all I can say about that is that it's not like I cherry pick you know, like which gender, not gender, but which ethnicity. It just depends on who gives us permission to use the pictures for presentations and for public and education use. And so it's not like I don't want to put people of color in it or anything like that. So keep that in mind throughout the presentation. I should be updating more pictures and also asking people to contribute if they're willing to. Of course, it's optional. Um, all right, some of these prerequisites, I do follow WPATH's SOC 8 version, but the problem, well, especially nowadays, but the problem is that the insurance companies are kind of stuck in the old version, version 7, and ultimately, whatever it is that they require, if they're asking for two letters, basically, you have to give them the two letters, even though I only require one or something like that, because of course they're the ones covering the surgery, right? Um, and of course, paying cash isn't viable for most people. So if they cover it and it's only going to cost like a copay or whatever, then um, you know, do your best effort to try to provide it and know that that's not necessarily a GCC thing or any other practice, but it's like an insurance thing. The procedures that are available in terms of this end of surgeries, this side of surgeries, of course, there's masculine and then there's feminine, then there's the neutral options in between are orchiectomy, plus or minus scrotectomy. There's, of course, the most common vaginoplasty, and then there's vulvoplasty, which goes by a lot of other names like limited depth, no depth. I'll go into that in that section. And of course, these surgeries can be combined with other things such as facial surgery, breast surgery, depending on what other body surgeries are requested and may or may not be sort of ideal or compatible to do at the same time. Um, so just whoever's had a consultation with me, I basically tell patients that there's a certain way that I was taught how to do these surgeries, and this is what my experience has been, and this is what I'm good at in terms of doing the surgery and keeping the major complications at a very, very low rate. Um, and so I recognize, and I don't say this is the only way to do this, but I just say this is how I do it. These are the reasons why I do it this way. And I do bring up other options such as peritoneal lining, let's say for vaginoplasty or other types of lining. Um, and ultimately, I've been saying this a lot to patients. I will tell you how I do it, why I do it, what my experience and whatever results and rates are for these things. And then if you feel comfortable with that, then fantastic. And if not, then that's totally okay. That's why we have options. Um, and there's a lot of major centers out there as well who are experts at doing vaginoplasty. They just, same thing, have their own way of approaching it. So there is a bit of a bias in terms of like what I'm offering because it's what I know what to do. So the goal of vaginoplasty is both aesthetic and functional. And so the functional portions is that we want not just for like the clitoris to work and have sensation. The majority of patients do report experiencing an orgasm or their first orgasm 3 to 9 months um, after surgery, but that can be quite variable. I've had patients tell me that they had it very early on, much sooner than the 3 months, but also patients that are a year out. I just talked to a patient that had surgery elsewhere, and they said that she heard of someone who had their first orgasm 7 years after trying for 7 years to have it, and then it just somehow activated. So, um, but most of the patients, I'd say 3 to 9 months. Can I absolutely guarantee it? No, I cannot guarantee. Um, I cannot guarantee that um, you will be orgasmic. No one can. No one can say that um, with absolute certainty. Ultimately, we're all humans, and as humans, we're very diverse. We're all built differently in terms of genes and predispositions. And so, um, sorry. So anyway, uh, so sorry, hold on. I can't get my I can't get my phone too. Anyway, so all right. So then the urethra, of course, I shorten the urethra, and I want to make sure that patients are able to void. That's a vital life function, right? To void. Um, and so the urethra has to be shortened. It has to be decreased in its girth and placed in the proper direction and the proper place anatomically for it to function well. And then the vaginal canal for those who seek a full vaginoplasty, of course, that has to be functional as well. And what that means is that it has to have adequate depth, but also adequate girth. And the way to achieve that, but also maintain it is through dilation. I'm sure many of you, especially those who are seeking vaginoplasty, are aware of the requirement for dilation. I'll talk about that in more detail later as well. In terms of the aesthetics, of course, we wanted to look um, like a vulva, right? The vulva is the word for external female genitals. So many of you, I don't put the slide up here, but many of you have heard of the wall of vagina, and that's a great example of the diversity, the anatomic diversity in women. And so it's this big, I guess, sculpture of impressions of people's vulvas. And they are very, very different. And that's the point. But I want my patients to be within that range and not be outside of that sort of that standard or that expectation. And so those are the aesthetic goals. Have the right parts, labia majora, labia minora, a clitoris, clitohood. But those can be achieved in different ways, and I'll go over that as well. Types of lining. Now, here's the thing, again, my personal way of approaching this is that I do skin-lined vaginoplasties. And where does that skin come from? Well, it just depends on the individual and what their anatomy is. Typically, usually, it's a combination of penile shaft skin and scrotal skin. For those who don't have sufficient tissue, I don't hesitate to take the skin from the groin, crease, hip area in order to have sufficient material to line patients from 5 to 6 inches in depth. My goal is usually 6 inches, but again, there's anatomical variations between patients, and sometimes I can get a little bit more than 6. Sometimes it's 6. Sometimes it's 5.5. And at times it's 5. But I do my very, very best to at least get to 5, especially in those cases where it is very, very difficult to create that space for the canal. And again, talking about anatomically correct and things being functional, the vaginas that we make, and it's not just me, but anybody who does this type of surgery, is anatomically correct. So trans vaginas aren't in some weird corner of the pelvis or off to one side, although I did see that one time. Not my patient, but no, it's anatomically correct. It's directly above the rectum and underneath the um, bladder and the urethra, which is where they all are. And so they are anatomically correct. So I use skin-lined vaginas, but the newer way of doing it is through the peritoneum, which is the lining of the inside of the abdominal cavity where obviously internal organs are, and um, the bowel and stuff like that. And so that's another way of doing it. It's usually done robotically. I don't do it that way. And it's got its pros and cons as well. And so that's something that if someone's interested in, obviously talk to those surgeons and, ask them why they do it this way. What are the pros and cons? What's their experience? Kind of thing. And then again, whatever way it is, if it lines up with kind of how you're feeling and sort of what you're looking for, then that's who you go to, even if it's not me, right? So, tunica vaginalis is another way of doing it. Um, and so that is the lining that wraps around the spermatic cord and the scrotum. And the testicle within the scrotum. And so that's another way of lining it as well. Xenograft just means graft that comes from another species. So there is such a thing as fish skin for lining, but I'm not sure where they offer that here in the US, but that is actually a way of doing it. I just think that there's better options before going to xenograft for lining of the vagina. Now, the other way of lining vaginas is through intestinal options, such as small bowel, which is done in South Korea, and colon, which is, I think, much more popular in Europe than here in the US. And so those are other types of tissue that can also create a vaginal canal. And again, everything has its plus and minuses. And so, again, ask the surgeons about that. And, at some point, those that seek surgery, have to pick the kind of surgery you want, but also the surgeon and surgery center. This is an example of where I take the graphs On the diagram where there's the marker, um, the drawing on the hip, that's the actual amount of skin that I take. But you can see that it's not just some open, big old wound in the hip. We do close it and we only take the skin. We don't take the fat underneath it or anything else or hurt the muscle. And the skin just gets brought together. And ultimately, it's a line scar in the hip area. Sometimes it's one side, sometimes it's both. And that is a criticism of using skin-lined vagina, especially for those who don't have enough. Whereas peritoneum, there's plenty of peritoneum on the inside. But having said that, there are certain limitations even for peritoneum, even though there's a lot of it inside. Dimensions, blood supply to it, things like that, that do also limit its use. Urethra. I'm a big proponent of having urethra, like post-op vaginoplasty or vulvoplasty urethras, be simply that, just a urethra and a pee hole, right? Because that's what it is. And so I put up an anatomical diagram of a cis female. And so you can see that, I don't know if you can see my arrow, but the urethra is just the urethra. You see how it comes out through here's the bladder. It comes out to the vulva. Here's the labia minora, the labia majora. And look, it just stops right there. It's just the pee hole, which is called the meatus. And so I want to try to reproduce that and try to make it match the natural result. And so, and it seems like, oh, well, duh, well, doesn't everybody do that? And that's not true. Some people use penile urethra to line a part of the vulva. And they have their own reasons. I've heard the reasons. It never clicked with me, and that's why I never chose to go to a place like that for myself, but also the reason why I don't offer it to others. And so I feel like urethra is very spongy tissue, so it's got quite a bit of girth. And because whether we like it or not, myself included, at one point, my anatomy was different. And yes, it is different. But our urethras in my community, our community is much bigger than the urethras in the cis uh, population. And so putting that thick, like urethra wall outside can cause problems. And I do see them with quite a bit of frequency and have to do alterations or literally just cut it out to solve the patient's bad symptoms from having that tissue. Again, it's not everybody. I'm not going to say like, oh, everybody that goes to a place that uses urethra outside of on the vulva has issues. I'd be lying. But I do see the problem patients only because I don't do it that way, and cutting it out usually takes care of the problem. So this is an example of what a healed urethral flap is. And so this pink area that's very well delineated, you can see the scar line and the difference between the skin and the middle portion. Again, here's the pee hole, right? The urethral meatus or urethral opening is right there. The vaginal canal is underneath. It's a little bit of a posterior vaginal web, which is not uncommon, but the vagina is below it. And this one happens to wrap its way around the entire clitoris. And one of the things that I have seen and had to treat is that because this tissue is very spongy, when it gets aroused, it can pinch off and cause problems with the clitoris. Again, it's not everybody, but I have seen it be a problem and have to take care of it. And this is just, again, anatomy. This is a diagram of what a urethra looks like. This could be male or female. It doesn't matter. The point is that there is girth to it. And like I said just a few moments ago, um, anatomically, our urethras are simply just bigger. So that's part of the reason why I think it's not the best idea to put it out there. Um, Now, of course, much of this tissue gets taken out in both vulvoplasties and vaginoplasties. All of the erectile tissue of the shaft gets taken out. Here's the urethra that's underneath. Of course, the testicles and the spermatic cord get taken out. For those who haven't had it done separately or previously. But you can see that the urethra, as you go back towards the inside of the body, here's the pubic bone. So once you get closer to where the prostate is and where the bladder is, guess what? It gets thicker. And guess what part gets left behind? It's this part. So this is where I try to decrease some of the girth. Of course, it's not perfect because it goes way, 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 way in there. But I do decrease its girth. Sometimes these can be very, very large. So I certainly don't want to use that tissue to line the outside, especially in the much, much larger anatomical patients. This is sent from a patient that came to me because they were having issues with that urethral tissue. You can see that it's swollen so much that it is literally bulging out through the labia. It's like the most prominent thing sticking out. This patient's dilating or using it illustrates two things, whether it's for sexual purposes or for dilation, that it just engorges. And so the other common thing that the patients that do end up coming to see me because of similar issues is that their partners oftentimes mistake the urethra, for the vaginal opening. So they're trying to stick their finger in there or things like that, which, as you can imagine, would be very, very uncomfortable type of stimulation to put things, for most people, I should say, to put things inside the urethra. Okay, enough of that. So anyway, that's not how I do it. This is an example of surgery that takes out the lining from a patient that's having issues with it. And so I cut it, and eventually, once everything's healed, guess what? Their urethra is now normal. Their urethra is just a pee hole, or what we call the meatus, which is a urethral opening. All right, dilation. Dilation is something that is mandatory. Every center has its own protocol that usually spans a period of about at least a year, where they have a specific sort of schedule and time that you have to dilate for and how long you have to hold it for. And the interesting thing is that they are very, very different, like really different. And again, I have my own protocol, and it actually hasn't changed from my days from being at the Meltzer Clinic, who is Dr. Meltzer is about to retire now, but he's one of the older and most experienced gender surgeons who are still working, at least for the next however long he's still going to work. But he's done most of these for longer than most anybody, right? Because he's been around. But he taught me to do this surgery, and in fact, I'm pretty open about it. He did my own surgery, my vaginoplasty, and I have not changed the dilation schedule. It's still my schedule for me, but also for my patients, is still the same. It's 4 times a day for the first, I think I listed out, 4 times a day for the first month post-op, and then twice a day up to 6 months, once a day up to a year or more, depending on how patients are healing. And after that, you start to slowly space it out bit by bit. Now, certainly, the first year post-op, sexual intercourse with whatever, a penis, a toy that is of the right size and length, um, shouldn't replace dilation. Okay, so you can have intercourse, but you should still dilate and follow the schedule, certainly up to at least a year. Now, I used to say like it can never ever replace dilation. Um, and that's not true. I do know patients, but also have friends who are post-op that don't really dilate anymore, you know, but they use it frequently and often enough. And they do check it once in a while just to make sure that things are still okay. But if it doesn't matter how good of a surgery I do, um, everything comes out okay. It cannot be ruined in terms of the vaginal canal anyway. It cannot be ruined by not following the dilation schedule. And it's not necessarily like, oh, so and so is just very irresponsible or doesn't want to do it or doesn't do it enough because they're too busy, they don't like it or whatever. But sometimes it is an actual real challenge, like a medical challenge. There are medical issues that are getting in the way of that patient who wants to make this work but can't because of pain, scar tissue, and other things. And so this is where not just my team, um, but any other team should be available to help patients get through some of these harder periods, especially at the beginning, on how to get through dilation. If you sort of fall behind and things kind of get tight, there are ways to try to make things better. And that can include pelvic floor therapy and other types of modalities to do our best so that the patient can get through it and get to the point where their vaginal lining is healed, but also stable. But it is very, very important. There are different types of dilators. These are the Meltzer design ones. I'm currently using those, but there's also the other ones, which are the colored ones. And so, just use them, follow your surgeon's recommendations for, the health of your vagina and the maintenance of it through a lifetime. This is a hard subject, which is the weight limitation for performing vaginoplasties. I think mine is 35. We do review it and take a lot of things into consideration as to where we do it or what we pick. I know that BMI is just a single number. It's not a measure of health per se. But it's something that does in some way correlate with the degree of difficulty or challenges that the patient can face post-op, but also for me as a surgeon in performing the surgery in the best way that I'm able to. But again, it's not just one number. I also look at other things like distribution, fat distribution, body proportions, and things like that to make a final determination. Every team is different. Some are very, very strict and their BMI requirement is very low, and I feel like I'm more on the lenient side, but I have had to change it over the years based on my experience in doing many, many of these. Ultimately, um, it's safety in mind, is not getting to a point where I'm compromising how well I can do a surgery for the sake of doing it, because bad things can happen. Vaginoplasty is a big, big procedure. It's complicated. And so, but that's why. But no one likes to hear it. But that's the reason. So these are just some examples of the first stage. I do perform vaginoplasty in two stages. It's the vaginoplasty or vulvoplasty. And 5 months later, I do something called a labiaplasty, and that is the second stage. But after the first stage, it's not like, oh my gosh, it looks like so incomplete. It's like so far off. No, it looks like a vulva, like this one, especially with the legs closed. It just looks like a vulva. Um, but if you really get in there and try to and like take a look or take inventory or something, like you'll find that, okay, well, there's a few things missing, but that's by design. And the reason why I still do the two stages is that I see a lot of single stage or all in one stage patients come to me for the second stage, and they don't look much different than my first stages, where I purposely don't put certain features um, in the first stage, in the vaginoplasty portion. So, but this is another thing that for those who have consulted with me, I also, pretty realistic. I'm not going to tell you that two stages is perfect, nothing ever goes wrong. No, that's not true. I went through the two-stage technique. I needed some revisions, and that was fine. It's kind of annoying, but fine. Everything's okay now. But so I'm not going to say, oh, two stages, it's perfect. Um, it's not like that. But I do think that the consistency of the final result is better and longer lasting in doing it this way. It allows the body to really heal, all the tissues to settle down before going in to put the aesthetic details in place. Just more examples of what the first stage is. I mean, when you look at it, it's like, okay, well, that looks like a vulva. It doesn't look like, oh, it's so incomplete, or it looks so weird because it hasn't had the second stage. It doesn't. And then the labiaplasty adds the little details: clitoral column, clitoral hood, labia minora, different example there. And so it completes the vulva anatomically by adding those features on there. Other ones, this patient is a vulvoplasty, which you can't tell just by looking at it. All right, so that's vaginoplasty. Vulvoplasty is every single step exactly the same as a vaginoplasty. You're not getting a lesser surgery. You just don't have a vaginal canal, but the clitoris is made exactly the same way. The urethra, again, I shorten it, I decrease its girth. I don't use any of the flaps to line the outside. That's the only thing that I don't do. Aside from that, it's not a lesser surgery. It's still the same recovery, 3 nights in the hospital as a vaginoplasty. There's still packing in there because I make a dimple, and that dimple has a little bit of packing to basically heal as a dimple. And I've heard different reasons. I don't really question it, other than I tell patients, like, okay, again, there's no shortcuts. It's just that I don't make the canal. But if someone wants a canal in the future, you don't burn any bridges. Now, certainly, certain types of lining aren't available anymore, like tunica vaginalis is ruined, because of course that comes from the scrotum and the wrapping of the testicle. So once vulvoplasty is done, that stuff is gone, right? Since I do skin line vaginas, of course, the hip, groin, area is still available for me to use, but then it basically guarantees that you will have the scars in the hips for me to line your vagina after a vulvoplasty. Peritoneal lining is a way of doing it, and that has minimal scarring. So that's another way of doing it. And of course, intestinal grafts and even xenografts, like I said, fish skin is also a option. So, um, but all of these years doing vulvoplasties, I have yet to actually turn a vulvoplasty and create a vaginal canal, although I just had someone as consult, and they may or may not have signed up for it, and they do want it, which is again no problem. We just talked about the use of grafts, and the good thing is that the risk of converting a vulvoplasty into a vaginoplasty is that no one has been through that perineal anatomical plane where a vagina should be. And so the risk of injury is no different than a first-time vaginoplasty. Whereas a redo vaginoplasty in the cases of previously failed vaginoplasties or complications from vaginoplasties, that's a whole different ballgame. That carries a lot more risk in terms of injury to surrounding regions, only because that whole plane is completely scarred, and can be very difficult to tell what's what. And so the risk of injuring other things is higher. It's still possible, and it can still be done relatively safely, but the risk is undoubtedly higher for those types of things. Gender neutral presentations is something that it's not just me. I'm sure every major center have seen requests for this. And so this is one of my patients who wanted full genital nullification. And so this is right after surgery. You can see the scar line. There's some sutures still in place. There's a bit of bruising in the middle. And where the catheter is coming out is where the urethra is. Of course, you can't eliminate that part because it's a basic, essential life function to void and poop and eat and things like that, right? And breathe. And so, there has to be a way out for the urethra. So this is just an example of that. Penile sparing vaginoplasty is also an option. And I mentioned this much earlier on. For those who don't want to undergo the major bottom surgery options, orchiectomy and scrotectomy with penile preservation is certainly a very good and safe option to undergo to achieve body congruence for yourself. This is an old example. It's not my patient, but it's someone that came in that had surgery elsewhere. I don't remember where, the US or internationally or something, but everything either pulled away or dehisced or was just placed too high. So the vaginal opening, you can see it's pretty obvious. The anus is below it, and the vulva seems to be on top of it instead of sort of framing it. And so I fix it. I created labia minora. It seems like it reaches all the way down to the butt, but it's what I needed to do to at least again frame and hide just a gaping hole, which is where the vaginal introitus or the opening is. For where I started, I thought I did a pretty good job, but this particular patient was still pretty unhappy with the result, and I get it, but there's only so much I can do. These are other examples that I've seen, or to credit Dr. Meltzer, some of these are his slides too. Some of these are patients that I've seen myself, and so some of these can be really hard to fix, and so My best advice is do your research, make sure that the surgery center and the surgeons you're going to are experienced, well-qualified um, surgeons. And like I said, ask the hard questions. How many of this complication have you had, or how have you dealt with it when you did have one? No one's record is perfect unless like you just started doing this. But anybody who's been around, now I'm starting to turn into getting into the group of the older surgeons now. Um, None of us have a perfect record, but we should all have a very, very low complication rate for the major things like rectal injury, urethral injury, bladder injury, which I haven't seen, but I'm sure it's out there. Um, but things like that, despite our good intentions and our high skill, it can still happen. And so, the good thing is that, we just try our best to try to fix it, or certainly recognize that it's beyond our own ability and get help from um, other surgeons, either from a different specialty or gender surgery as well, to try to help patients get through these things. So that's the sort of the honest thing, rather than saying, "Oh, this never happens to me," like I'm perfect. Um, but anyway, so so that's my talk. It's a lot of information.
Yeah, thank you so much, Dr. Lay, for sharing all of this and also just like sharing the realness of just how complications can happen too. I'm glad that you're kind of showing both sides of things of like the successes and some of the things that people can expect as well. I think it can feel a little bit scary, but better to have that information and be real about it as opposed to hiding it or like ignoring it, you know? So yeah, thank you for that. And also thank you, Rosie, for answering some of the questions in the chat. We do have a few coming in the Q&A, so I can go ahead and tackle some of those. How does that feel for you, Dr. Lay?
Yeah, that's great.
Sweet.
Sorry, I'm hiding in the closet. Someone pointed that out. I'm like, I was at the hospital. I had to cross the bridge. I live in Berkeley, so I had to cross the bridge.
Yeah.
There's been a lot of motorcycle um, accidents that I've seen just in the last month. And so I'm like, okay, I'm gonna take it easy.
Mhm.
Um,
Yeah. And that's rough traveling across the bridge to get to a presentation as well. So yeah. But to tackle some of the questions, um, this first one is, do you have to remove the lower hair before surgery? If not, what happens to the hair in that location?
okay, so that's a very good question. I don't require scrotal electrolysis, but I do highly recommend it. And I recommend electrolysis over laser, although a lot of centers are doing a combination where they do laser first and then electrolysis. Again, we're all humans, and so some people react very well to just laser, and um, the hair basically permanently goes away. And for some people, that doesn't work, especially light-haired um, people. And so then electrolysis is what needed. Um, and my biggest advice about the hair removal is that you go to a reputable like electrolysis center, because there is a lot of variability um, on that. Because after completing months and months of this, I do the surgery, and I find a year later that I'm doing an exam on the patient, or I'm doing the labiaplasty months and months and months later. Um, and there's a bunch of hair in there, and they're like, "Whoa!" But I went through a whole year of this. And so I think there is some variability in that. So no different than seeking out, obviously, a good surgery center. Seek out good places for electrolysis, because the last thing
Mhm.
you need is a bunch of hair inside. Ultimately, there's no real functional problem per se, but things get caught in it. It's a hygiene issue, infection, and I've seen it where it's matted, it's full of gunk, all caught up in the hair.
Mm.
And it's just, it's unpleasant. Of course, if you choose peritoneal lining places, of course, then you don't have to have it done. So again, um, it depends on what type of vaginoplasty you're having done. But I personally do recommend, since I do skin line vaginas, hair removal at a competent place.
Got it. Thank you. Someone says that they're post-op and lost their clitoris while cleaning. Could that be repaired?
Lost the clitoris after cleaning, did you say?
Mm-hmm.
What
That's
do you
what
mean
they said.
cleaning? Mm.
Um, Not sure, but that's what the
Okay.
they asked. Yeah.
All right. So I have seen patients who have had surgery, and then their clitoris necrosis, or sometimes it's not full necrosis, sometimes it just gets buried. It tends to happen more frequently in heavier patients, but I've also seen it in skinny patients. And so it really depends on how much of it is left or whether it's simply just buried and it's a matter of
Mm,
basically digging it out, right, and externalizing it again. And so that's one of those things where you have to, go see a surgeon to determine like, what's there and what can be done. But I have seen patients who have completely lost it. They have no sensation. Um, it's so it can happen.
mhm.
It's rare though. It's very, very rare.
For sure.
And I'm sorry if it truly like went away and there's no way to solve it. I'm sorry that that happened to you.
Mhm. Yeah. This person asked, is it true that there can be some personal lubrication generated from the robotic assisted pull-through technique?
That is true, but it's variable. So I know most of the gender surgeons here in the Bay Area, but also um, knowing them over the years, and I see them at meetings, the professional like surgeon meetings. Um, and the thing about peritoneum, from the peritoneum surgeons is that it's kind of variable. Some people are totally dry. Some people won't stop leaking fluid, which I feel like that would be pretty awful. Um, and for some people, it's inconsistent. The one thing I will say about lubrication of neovaginas, right? The vaginas through gender care, is that most of the time they're dry, unless you're talking about intestinal options. But they're never connected, unfortunately, they're never connected to our sexual brains. Does that make sense? It's not like you get aroused and all of a sudden your lining, gets wet per se. I don't take out the prostate and I don't take out the seminal vesicles. And depending on the person, if they happen to be productive, it's that pre-cum fluid that can come out of the urethra. But see, that's the thing. If that fluid comes out through the urethra because it's right on top of the vaginal opening, could it potentially be enough? I wouldn't say no. Um, but you
Mhm.
have to be the kind of person where you're very productive and you're very turned on for to have enough of that pre-cum material to serve as lubrication. But the lining itself usually doesn't have um, sort of sexually connected good enough lubrication. Again, unless it's an intestinal option, then there's mucus all the time,
Got it.
nonstop.
Oh, good to know. What would be the difference between a limited depth vaginoplasty and a two-stage vaginoplasty procedure? Someone is trying to understand how the approaches differ, with like the method, recovery, and long-term outcomes.
Well, the vaginoplasty and the vulvoplasty is exactly the same thing. It's just that there's no canal. And so recovery isn't much different, although I will say that because of the maintenance of the vaginal canal and the dilation process, that it certainly is more challenging to recover from a vaginoplasty because of the maintenance of the vaginal canal, having to dilate. Um, but long-term general functionality, of course, one has a vagina, one doesn't. Um, Again, orgasm, sensation, peeing, aesthetics should be um, very similar. I don't know if
Hmm.
that answers the question.
Hmm. Yeah, I think it does.
And it's also two stages. Sorry, right?
Yeah,
It's also two stages again because they're really not different. It's just a matter of canal or no canal.
I see. Great. Would having diabetes affect my eligibility?
It does not. It does not. But just like any other comorbidity, not just diabetes, heart disease, lung disease, kidney disease, you know, bowel disease, right? Celiac disease, ulcerative colitis, things like that, doesn't keep you from having surgery per se, but it has to be well controlled. So you're asking about diabetes specifically, your HbA1c and your sugar control should be very stable and within the normal range in order to proceed because it does make a difference. And it's not just gender surgery, it's just obviously general health, but also other types of surgeries.
Hmm. Yeah, and kind of following up with that, another person asked,
Uh-huh.
would there be any issues for folks who are underweight for a weight limitation too?
Um, no, there really isn't, but it also just like a high BMI, a very low BMI also catches a bit of a flag, right? Of like, oh, wait, does this patient have, and what comes to mind is do they have an eating disorder, which is not uncommon in our community. And so we just want to make sure that the patient is just naturally skinny, right? Again, we're all humans, right? And we're all different. So some people can eat anything they want to stay skinny, but they're very healthy. But if it's an eating disorder or something that's causing them to have that, then of course we want to know that uh,
Hmm.
prior to surgery. In terms of the surgery itself, the low BMI on a healthy patient, right? Not eating disorder, not some, you know, bowel disease or something that's causing them um, to be skinny is that there's less, as a surgeon, I feel like there's less sort of cushion, less room for mistakes because there's less padding everywhere, even on the inside of the pelvis. And so you have to be, I certainly am much, much more careful in the very skinny patients because I know that my margin of error is a lot tighter.
Hmm.
But
Makes
it's
sense.
normally, again, my record's so low that it's, you know, I can get through it. It's just I'm extra careful with not just the heavy patients, but also the very, very skinny ones.
Hmm. Cool. Can you have a tunica vaginalis lining done post-orchiectomy if you still have scrotal tissue?
I don't know that you can because there's nothing holding it open anymore, right? Because the cord is gone and the testicle's gone. Um, I don't think so. Of course,
Hmm.
I don't do tunica, so that's something to ask the surgeons, but just thinking about it,
Hmm.
I
Hmm.
don't think so.
Yeah, cool. For dilation, is it something that you would have to do for the rest of your life?
Um, You have to do some form of dilation. It does get easier, especially if you're able to maintain it well. But I have had patients who, again, like I said, that don't dilate, but they use their vagina um, for penetration frequently enough with something big enough. It doesn't matter what it is, right? As long as it's being used and it's the right size and you know
Hmm.
length and whatnot. So I used to say never, you had to die forever. It's kind of true, but if you just had to check it every 3 months because you're having so much like intercourse, then, it's not that bad.
Mhm. For sure. Another
You have
person
to be lucky
asked,
though, I guess.
right. This person said, I've seen before and after photos from a few different surgeons. Some of the after photos um, can look really nice and neat looking, and then others look a lot. This person used quote unquote roast beef sandwiches, unquote. What are the different factors that come into play with the outer appearance?
Um, I think that even among gender surgeons, we all have kind of an ideal in our heads of like how we want it to look. And it is interesting that even though the overall outcome is good, I would say, but they're still different. And I think that has to do with sort of like the ideal of that surgeon. But what the other thing that plays into what any vulva looks like is what we're starting with, anatomy. And I keep going back to this. We're all humans, right? Humans are humans. We're all different. And one of the things I will tell my patients, and if you've been my patient, I might have even said it to you, is that I just try to make the best version of a vulva for you, given your anatomy. So if you're skinny, well, guess what? It's going to come out like a skinny vulva. If you're heavy, it's going to look like a heavy person's vulva. If you're if your perineum is, or your pelvic area is like anatomically long, what I consider long, um, then things are, the incisions and the scar lines are a bit longer just because of the dimensions. But I try to make the best version for each patient. But since I do it in 2 stages, I feel like most people do come back for the second stage. And insurance, if they contract with GCC, does cover the labiaplasty. So then I know that, you know, at the second stage, I still have potentially, if I need to, room for improvement, right? I can still work on things at the second stage. So I'm not just making labia minora. I'm also looking at everything else that I can improve upon.
Mhm. Amazing. And then another one is it easier to work with clients who are well endowed or clients who more or less have less than average size? Does it matter?
Uh, it is from the sense that there's enough tissue. When folks don't have enough tissue, then even though it's not necessarily an added complication per se, it's the fact that now I need more skin to work with, or I need to add skin in order for things to reach. Um, but I've also seen patients who are not necessarily just well endowed, but they've tucked for so long that they have really honestly damaged their anatomy, their genital anatomy. And so excess skin can be a big, big challenge. So on that spectrum of things, especially if it's due to like chronic tucking, um, it can be very challenging. Not just doing the internals is the same, but creating the vulva, making it look good is a challenge because everything's so stretched out. So
Got it.
I've definitely seen that.
Good to know. Um, let's see here. Is there a oversight organization that like folks should be looking out for a surgeon being a member of, like WPASS certification? Is there anything else that people should be looking for?
Yeah, of course. I think the first one, I guess even more than just being part of the community in terms of the professional communities like WPATH or US Path or whatever country they're from, um, is that they are board certified surgeons in the specialty that they say they are. There's an issue in plastic surgery where cosmetic surgeons, it's like so generic. Most people think, oh, cosmetic surgeon, they're plastic surgeons. there are people who are radiologists that are doing cosmetic surgery and calling themselves cosmetic surgeons. And so you want to make sure that if it's a urologist, if it's a urogynecologist or a gynecologist, and certainly like me, a plastic surgeon, that we're like the real deal, right? And we're not like some cosmetic surgeon who's like
Hmm.
background is dermatology or not to bag on them. They're very smart people and qualified. They're just not surgeons from the sense of like what we've been through to become who we are and going through all those steps. So
Hmm.
um, making sure they're like the real deal, basically. And that's a problem not just in gender surgery, but like I said, in aesthetic surgery, especially in
Hmm.
my field of plastic surgery. A lot of non-actual plastic surgeons doing cosmetic surgery for the money.
Got it. Are you able to, or could you elaborate a little bit more about the pros and cons of the different vaginal lining techniques, like the penile skin, peritoneum, and tunica?
Sure. Well, I'll start with skin. So skin has been around the longest, is the most well established. Again, it's not perfect. Like I said, I pointed out some of the issues that can happen with post-op vaginoplasties, and that can happen with all the other linings too. But skin can have problems. You can get infections of the skin inside. Um, if you have a skin disease to begin with, right, a skin condition, especially when it affects the genital region, it'll obviously be carried over into the vaginal lining. But now it's harder to figure out because, of course, it's in the shape of a vagina. And so it's a matter of, um, you know, being aware that you have a condition and then get checked up and get vaginal exams more frequently. Otherwise, it's once a year. Peritoneal lining, most of the time, once it's externalized, it dries up. And what I mean by dries up is that because of its new location and what it's exposed to, the body knows. And so it epithelializes and changes to meet the conditions. And so um, it can be just as durable. It can also end up with granulation. It can also shrink if you don't dilate. And like I said, one of the problems is that it can just like be always leaking too. So, and from talking to the surgeons that do peritoneum, once you have a peritoneal lining vaginoplasty and it goes bad, you can't reline it with peritoneum anymore. That's what I've been told. So you'd have to seek another type of vaginoplasty, either skin lined or intestinal options to fix that. I can't confirm, but one of the surgeons, um, that works at the hospital, we were talking about something, and they said, "Oh yeah, we can't redo it if it goes bad. If it's already,
Oh,
it's a one-time deal, apparently."
oh, that is really good to know. I did not know that.
Yeah, but it shouldn't keep you from not having peritoneum. It just means that if something goes bad, you just have to seek another way of doing it.
Yeah, I see.
So,
There's two regarding, or a few regarding recovery. How long before driving is doable?
um, well, I think it's individual. It's uncomfortable the first, I'd say 3 weeks because of obviously the anatomical area, right? Everything's swollen down there. You sit on it, there's pressure. Um, but it really depends on the person. It can be the biggest thing is that you not be on narcotic pain medication, right? While operating anything, any like machinery, car, or anything like that, or whatever, farm equipment or something, right? Um,
Hmm.
so I mean, I'm trying to think of my own path. I was driving out of the hospital, but I was off the pain meds by then. So, um, I'd say 2, 3 weeks.
Got it. And I think thank you, Octavia. I don't think we talked about the tunica vaginalis lining, pros and cons of that one.
Um, Well, I don't do that one.
For sure. That makes sense.
But of course I do see it. But one of the centers here in the Bay Area does do tunica vaginalis.
Hmm.
I do think that it does has limitations as well, right? Because it depends on how big the scrotum is, how big the testicles is, how low they hang, right? Because that's where the material comes from. Um, but I also think that once it's externalized, it dries up. I can still have granulation. It can still shrink if you don't dilate it. So it's really, honestly, not that much different um, than having skin or even peritoneum, like I said.
Hmm.
The basic challenges, you still have to dilate, you still have to maintain it. They all have, all of them, even including intestinal options, can scar down on you.
Hmm. Hmm.
It doesn't matter what lining, unfortunately, for now.
Yeah, that makes sense. We have a couple different questions left, so just wanted to give you like a gauge. Maybe we have about 5 or 8 left, but some of them we can go through pretty quickly. This next one is how long do you need to use the catheter, and how long before you can exercise?
Um, Exercise, good questions. Exercise, again, it depends on any individual's recovery. But if you mean like walking and stuff like that, coming out of the hospital, you're going really slow. After 2 weeks, you can do some decent walking. I'd say for the average person, you're not running. You're certainly not riding a bike. But I'd say 4 to 6 weeks, and you can start ramping up on an exercise routine, maybe not heavy stuff like CrossFit or something like that.
Hmm.
Um, Maybe not that. And of course, if you're into like, you know, mountain biking or something, that's probably that might be 2 months or more. And then in terms of what was the second one?
Second one is about the catheter.
Oh, the catheter stays in for about a week.
Cool.
So it comes out the day after dilation, which is usually 6 or 7 days after surgery. If for some reason someone can't pee, um, and it goes back in, then it stays another week. So,
Hmm.
um, but it's not that common. Most of the time, it's 1 week.
Hmm. Got it. This one is around hair removal. They were asking about thoughts on electrolysis prior and then the cauterizing of follicles during surgery.
That's another question that is asked a lot. They call it I haven't heard it called cauterizing follicles, but they call it follicle scraping. I hear that a lot
Hmm.
in our community. And what I tell patients, especially for the surgeons that use scrotal tissue, right? Because otherwise, peritoneum has no hair and tunica has no hair. So this is more specific to those who use um, either penile skin or scrotal skin as graft. Is that, the goal isn't to scrape the graft for the sake of getting rid of hair. The goal of thinning the graft is for it to survive inside the pelvis as a graft. And in order to do that, it has to be very, very thin. Um, and so the byproduct or the positive product of preparing a graft to be taken as vaginal lining is that it does end up scraping the layer or cutting out the layer that contains most, right? Not all, most of the hair follicles. And so that's what um, follicle scraping is about.
Awesome. That is really good to know. Is there a preference for doing an orchiectomy before vaginoplasty?
It's very individual. Some patients aren't quite ready because of insurance or they're just like their point in life. They're waiting for vacation or to finish college or to finish grad school or whatever. And so rather than keep going, then keep waiting. They want to just stop taking the anti-androgens. So then I think it's a good idea if you're a year out or longer. If you're within a year, you should probably just wait. The other thing is that some patients are very intolerant of the anti-androgens. They actually either have severe allergies or severe side effects from taking things like spironolactone,
Mhm.
especially when it comes to like potassium levels and things like that. Um, and so for those patients, it's hard to sort of feminize when there's so much testosterone activating everything. So in those cases, an early orchiectomy is a good idea, even if it's not like a whole year out before vaginoplasty, because of true like medical reasons.
Great. And then this person, you had mentioned doing two-stage for your surgeries. Um, are there other types of surgeries that would take multiple surgeries? Like, what would it be? What would be involved in doing multiple stages of surgeries for a vaginoplasty?
Uh, well, the standard for me is to offer two stages. It's the vaginoplasty, which again, it's the construction of the vulva, the canal for those who want it, the urethra, the clitoris, the majority of the appearance of the vulva. And then the second stage is 5 months minimum to allow the tissues to really heal, and then come back and do the aesthetic features
Mm-hmm.
of the vulva, like labia minora, clitoral hood, clitoral column, rearrange the labia majora, but I fix anything else that needs to be fixed. The urethra might point in the wrong direction or might have some scar. The vaginal entrance might have a web, like I showed in that one picture. Um, and anything and everything I can do to make it better, I try to do at the second stage. And again, it's not perfect. Sometimes I do need a revision even after the official second stage. So
Mm-hmm.
everybody gets offered two stages. Some people never come back for the second stage. They're super happy and they don't care for the labia minora or the clitoral hooding or something like that. And so
Mm-hmm.
it's under, you know, I don't force anyone to have the second stage, but most people do come back.
Mm-hmm. Cool. Is 6 inches the maximum depth, and is that typical of cis women as well?
That's also a very good question. So my goal is to reach as close to 6 inches as possible. Have I ever had one that was deeper than that? Sure, but it wasn't necessarily because I was like, oh, let me try to get 8 inches on this one. It's not like that. It's just that I always aim for 5 to 6 inches. But sometimes things just open up. Tissues are very stretchy. And with dilation, consistent dilation, people have gone beyond 6 inches. Um, but there is a limit to how deep we can go. Now, the question comes up as like, okay, well, what does a cis or natural vagina measure? Um, the hard truth is that it's not the same. For better or worse, it's not the same. Now, I have an artificial one, so I'd be lying if I said I didn't wish I had, a natural one, right, with all of its qualities, but I just don't. And so, there's a certain limitation. If you can imagine, women go in for pap smears or vaginal exams, and the doctor just, they do a digital exam, and oh, they can feel the cervix and all this stuff just with their fingers. Well, most people don't have 6 or 7 inch long fingers, right? So it's pretty short at rest, 3.5 to 4.5 inches at rest, maybe 5 inches at rest. But but we all know that it's just different. It stretches. Obviously, babies come out of it. So, um, totally, totally different. And I'm sorry that it's a hard truth. Um, and maybe someday in the future, probably not in my lifetime, but maybe in the future, genetic engineering can change that.
Mhm.
But it's just different. But it doesn't mean it's bad. It's functional. It works. It can give you pleasure. You just have to maintain it, obviously. Um, and you know, it can be quite normal, right? Normal.
Mhm.
But you know what I mean? I can't sugarcoat it to be like, oh, it's the same. It's because it's just not.
Hmm.
It doesn't mean it's bad,
Hmm. Yeah.
right?
And I feel like it's also like really great to have your unique experience, both as like a surgeon and also someone who's experienced the surgery too. Like that's a lot of like experience to be able to share to other people too, of like what to expect.
Yeah. Yeah, that's true. You know what? I've actually complained to some of my patients. I've been to these professional meetings. There's a whole panel of people at this meeting. They're all cis and they're all discussing dilation. Like, hello? Like, you could have at least put me on the panel, someone who actually freaking dilates,
Hmm.
instead of arguing about, like, you know, in a way, it's sort of like, cis guys talking about periods because they're the experts.
Hmm.
No way.
Hmm. That's so ridiculous. Like you're
But
literally right there.
okay. And that's not just me. I just happen to be a surgeon, but there's other health providers within WPATH who are also trans and dilate. Put some of those folks up there,
Hmm.
who
Absolutely.
actually know what it's like instead of arguing about, oh, it should be this or that. Like, you guys have no clue.
Right. Exactly. Like
Anyway,
center the people with the experience.
anyway, so it's just kind of amusing sometimes.
Hmm. Yeah, absolutely. There are some questions here that we have answered, things around age, both young and old. There's going to be, you know, like mileage might vary, personal experiences. It's all dependent on every kind of surgery. For risk and health factors,
Right.
um, uh, there's one question here. Um, Around how do doctors determine if there's enough penile skin? Is it from a soft or erect penis point of view?
Um, it's actually from a soft point of view, and so there's a particular way that I determine that, and it's usually during an exam. Of course, if it's an in-office exam, I have a bit of an idea, but the patient isn't asleep, and I pull. It's like it's the most uncomfortable thing for me to like do what I do in surgery when the patient's asleep to really get to it. I've done it a few times for patients that are like, go for it. Like, I'll just, take it. But I really want to know if you think I have enough. And so it's a matter of stretching it and seeing how far it reaches from the base to the
Mm,
perineum, which is where the vagina has to be. Remember, trans vaginas aren't in some weird like corner of the pelvis. It's anatomically correct. So it has to reach and then I also sort of tent up and pull on the scrotum, the appropriate part of the scrotum, to see how stretchy it is. And in surgery, obviously, I have a ruler, right? Um, and then I can determine if someone needs extra graft or not based on the measurements of the penis on like max stretch and the scrotum to figure out if someone has enough. So,
mhm,
um, there is a method to it that I use anyway. And again, it's no different than, how I was taught. And so I haven't changed it. And it seems to be pretty consistent as to figuring out who needs graft and who doesn't need graft.
mhm. Great. Um, let's see. I think that there is one question around having to do reasonably intense exercise for work around adrenaline sports, which I think you had addressed already. They had mentioned things around skiing, downhill, mountain biking, parkour, et cetera, et cetera. What would
Um,
be like a realistic time of recovery for that?
okay, so those are pretty extreme sports, right? That's awesome that
Yeah.
you do that. Um, I'd say 2 to 6 months, depending on the person. And even at 2 months, maybe you're getting back into the training part of it. And then you ramp it up as you go. Um,
Hmm.
eventually you can do anything you want, right? Once you're healed, you can do anything you want. It's not gonna, you know, hurt it per se, right? Unless you literally traumatize it by falling on it or something like that, right? So. Um,
Cool. And then these two are related to orgasms, which would be the last ones that I'll ask. The
okay.
first one is around have you heard of any one receiving the surgery being able to squirt? And then the other one is this person can only have an orgasm with their partner. Is there possibly a reason of not being able to have one by yourself?
I I haven't heard that one, where they can't self-stimulate to orgasm, but only through a partner. Um, but I'm not sure where that question was going for, whether like how can I pleasure myself to orgasm? Is that the problem?
Hmm.
Anyway, so but aside from that, the squirting thing, again, I don't take out seminal vesicles, I don't take out the prostate. If someone is productive, I suppose you could quote unquote squirt. Um, because as you orgasm, something does come out for those who are semi-productive or very productive. You literally do ejaculate. It's just that it's not semen anymore because the testicle and the epididymis is gone.
Mhm.
And so it's not white and the color. It's just clear fluid. But it's not everybody. And I think even in those who are productive, it's variable as to how much comes out. Um, but it's very individual, right? Everybody's different. Again, the whole human factor that I talk about. Some people are consistently productive and some people are not at all, even though all the same organs were left behind, right?
Mhm. Oh, sure. And that is basically our last question. The one that is up is around like another office's practices, which I think that we want to just focus on talking about your experience in like gender confirmation center right now.
Yeah.
And so like sorry we won't be answering that question for the person who had asked that, but that is basically going to be the end of our presentation. I would also love for you to be able to share a bit more about like your own practice at your surgery center at gender confirmation center, like where are you based, where can people like get in contact with you to get a consultation, all of those things.
Yeah, well, we are based in, so gender confirmation is based in San Francisco. We are in the downtown area, Union Square. Area. We do have a private surgery center, but it is an outpatient type of center where we do a lot of top surgeries, some facial surgery, some bottom surgery. But again, it's limited by the fact that it's not a hospital setting. So bigger procedures are not done there. But we also have affiliations with different institutions such as UCSF St. Francis. Memorial Hospital, which is where I do most of my bottom surgeries. But we also have privileges at other medical centers around the Bay Area to do surgery. And it's not just me, it's all the surgeons within our practice. In terms of contacting our office, maybe Rosie can answer that in the chat or the messaging.
Mhm. Yeah, and I just put down the website for the gender
Oh
confirmation
yeah,
center in the
yeah.
chat as well.
And we're in social media too. I know for sure there's an Instagram account. There might be other social media venues where we announce certain events such as the Plume Talk, but also other things from patients that have come through our office and want to share their experience. Um, and other things. So occasionally there's tidbits about the providers themselves. Uh, like me, I think in January they might have posted something about me being crazy and riding my motorcycle or something.
I
Um,
love that.
or and so, but I think there's pictures of I think Dr. Mosser with his kids or something.
Yeah.
You know, but yeah, but yeah, I guess go to our website. That's probably the easiest way.
Mhm. Yeah, and thanks,
Unless you reach
Rosie,
out to
for
me. Yeah.
sending out the contact form as well.
Yeah.
And
Enough.
we'll also make sure to send it via email when we send out the recording too. So if you end up losing the link, don't worry, we'll get it back to you maybe like early next week. I will be editing the video tomorrow. So yeah, but thank you so much, everybody, for being here. Thank you so much, Dr. Lay, for just your presence, your amazing expertise, education, all of the things. Also for running around on your motorcycle just to get back home and getting to this event, you
My
know?
gosh. Yeah, I need
um,
to get GCC to change that glamour shot of mine that they um that they put up because at one point I did look pretty. Now I'm
you
old.
do still. What are you talking about?
I'm old and you know, today especially I'm a bit disheveled, but
No, nonsense. It is hot today though,
it's
so.
hot. It's really hot. And I wear all the gear, so I literally walked in the door and you know, got set up before the meeting actually started. When you first saw me, I'm like, there's sweat dripping down my back. It's hot out there.
Hot and in traffic and yeah.
But anyway,
Yeah. And
yeah,
also
thanks
thank you.
for
Yeah,
putting
and thank you so much, Rosie, for
appearance.
yeah, thank you so much, Rosie, for being here as well and just like moderating and everything. And answering questions in the chat. Your presence was amazing as well. To kind of end things off.